Okay, so our patient today is a 35-year-old male, full code, he's 95 kilos, and his BMI is 26, and he's here for a septoplasty. So first I'm gonna go do my machine check. So I'm making sure that my machine is plugged into the wall, and that my pipeline pressures are 50 PSI, and then my O2 auxiliary tank is full. I'm gonna check my vaporizers, make sure the screws are on tight here, that they're nice and full. I'm gonna check the interlock system to make sure that that's working. While my machine is off, I can do a low pressure test. And then I'm also looking at the CO2 absorbent to make sure it is not desiccated. And I'm gonna make sure I have my ambu bag that works, my suction, my proper monitoring equipment, EKG, blood pressure cuff, and tidal, and pulse ox. And then I'm gonna turn on my machine. I can do my O2 analyzer test, and I'm gonna check to make sure I can't make a hypoxic mixture here. And then I'm gonna make sure that these vent settings are appropriate for my patient's height and weight. And then I'm gonna do a high pressure test, close the APL valve, occlude, press the O2 flush, and I should be able to maintain 30 centimeters of water for at least 10 seconds, which I do. And I'm checking the inspiratory and expiratory valves to make sure that those are fluttering as well. And and then I'm gonna have my Apple's drugs prepared as well and set up my room with my equipment. And I have a Mac 3 for him. I have a 8.0 ET2, and I have a half size or a size below and above. And I have an LMA in my drawer just in case I need it for his right size. And I have an oral airway. So next I can go assess my patient in pre-op. And I'm gonna ask my patient, have they ever had anesthesia before, any problems with anesthesia, any patient or family history with problems with anesthesia, specifically malignant hyperthermia. What did you have for breakfast this morning? He didn't have breakfast. Are they on any daily medications or any health problems that I need to know about that are in his chart? No. Allergies, no allergies, hasn't had a recent cough or cold. And next I'm going to assess his airway exam. So his incisor gap is adequate. I'm going to assess thyromental distance, head and neck range of motion, which is good. There's no paresthesias. And I'm going to assess his Mallampati, which is a Mallampati 1. And so he should be a good, easy airway. So next I am going to transfer my patient to the OR. And I'm gonna start pre-oxygenating him for 3 to 5 minutes. With a nice tight EC seal. As my patient is pre-oxygenating, he already has an IV in place, and we're just doing a final monitoring check here, and make sure that all the monitors are on and the settings are appropriate on the ventilator. Next, I'm going to push my induction drug, so he's going to get 200 milligrams of prop, which is 2 mg per kg, and then 50 mics of fentanyl, and 95 milligrams of rock, which is 1 per. Now that he's fallen asleep, I can tape his eyes, and then I'm going to make sure that I can mask ventilate. I can deliver a breath, which I can, and now I can intubate. So I'm using a Mac 3 and an 8.0, and I can see cords and corniculates here. And I'm going to assess the depth on my tube, which is 24 centimeters. and I'm gonna already see the misting in the tube. And then I have bilateral breath sounds, and I'm gonna check my end tidal for confirmation that it's in his airway. And then I can tape down my tube. I'm in place at 24 centimeters. And then my patient is gonna be a TIVA, so he's gonna be at 200 mics per kg per minute on the propofol. And then he also, I'm gonna leave him on the vent settings of assist control 12, 8/5, and 30%. Okay, so we're gonna do the case. After the case, I'm gonna get ready for emergence. My patient, I'm gonna do a deep extubation because he has an ENT case. So first I'm gonna check my train of 4, and I only have I have 2 twitches. So I'm gonna give sugammadex to reverse. I'm gonna do 2 mg per kg, which is 190 milligrams. And then I'm gonna place a bite block, or not a bite block, but an oral airway. Okay, and then I'm gonna do really thorough suctioning because you can have risk of laryngospasm with deep extubation. Okay, and then I'm gonna do my pre-oxygenation before I extubate. Before I extubate, I'm gonna make sure that there's good spontaneous breathing, adequate tidal volumes, and regular ventilation. And then I'm going to deflate the cuff and extubate. And I'm going to provide support with the mask. And I'll still have emergency airway supplies, reintubation supplies, and adjuncts are here and available as necessary. So now I'm going to be ready to take him over to PACU. And I'm going to give PACU a heads up. I'm going to collaborate with the PACU nurse and the OR nurse as well. It's really important to do face-to-face report if possible for report and a standardized handoff. So my handoff is, this is my patient, Nick Garrett. He's a 35-year-old male, 95 kilos. His BMI is 26, and he's post-op from a septoplasty. The case was about an hour with Dr. Oakley as a surgeon, and I was the CRNA. He does have a history with difficulty breathing and chronic sinusitis. He also has no current daily medications, and he has no allergies. The patient will be discharged with 2 Rhino rockets in place in both the nares. And then for the events in the OR, he was on a general anesthetic with TIVA, and he was intubated with propofol, rock and fent, and an 802. He has an easy airway. The last opioid administration was fentanyl at 9 a.m. and he also got reversed with sugammadex. He also got Zofran at the end of the case to prevent post-op nausea and vomiting, and no labs were drawn. For eyes and nose, he had less than 100 of EBL, and no urine output was counted. He does not have a Foley, but he voided right in pre-op before we left for the case. And then I gave him a 500 in pre-op and 500 of crystalloid intra-op as well, which is still running in his IV. His last vital signs were BP 134/70, heart rate is 80, respiratory rate is 12, and he is statting 98% on 10 liters face mask. He's drowsy, but he's following commands and he's comfortable. So I'm going to write in some orders, and I would like us to prevent post-op nausea and vomiting, so I have PRN Haldol to manage that as needed, and then he also has IV Toradol and fentanyl PRN as well. And we'll do just the routine monitoring with vital signs, and the patient will be discharged with his wife and the nearest PACU.